fifth vital sign. When you do the blood pressure, respiration rate, and temperature, heart rate. So always ask about pain. Pain is what patient is telling you. So it's subjective. It's based on patient telling you the degree of the pain that they have. So, and you have to follow with that. So the reason for pain is to protect our body. So as you can see here, if you touch a hot surface, if your hand goes over the fire, what's going to happen next? So you're going to remove your hand very quick, right? And after you remove the hand, if there is a burn in your hand, what are you going to do? Cold water, ice, put it in freezer, cry, scream, right? So again, there are two things happen when there is a pain stimulation. So the first thing is unconsciously involuntary response from the spinal cord. So that's you remove your hand as quick as possible before even your brain kind of digests that information. So which is very important because the time is essence here. And then the brain get a chance in about a second or two to analyze the information, and you're gonna get the full response to that painful stimulation. So you remove your hand without even noticing it, the hand removes, and then your whole body moves. You start screaming, crying. Everything after that initial move of your hand is going to be controlled by your CNS and the brain. So we have two types of pain, nociceptive and the neuropathic. As you can see, the nociceptive pain usually related to tissue injury, and neuropathic pain, sometimes there is a a nerve injury, or sometimes it's just a dysfunction or imbalance of the electrolyte around the nerves. So the treatment is different. Nociceptive, you get opiate medication. For neuropathic pain, usually anticonvulsant, anti-seizure medication works better for the neuropathic pains. Now going back to the nociceptive pain, so there is an injury, right? So you break arm, leg, you cut your hand, punch the wall. So all those things, you have a kidney stone, GI bleed. So these all considered as example of the nociceptive pain, which there is a tissue injury, tissue damage happening that causing that pain. Now there are 4 phases for the nociceptive pain. Transduction, transmission, perception, and modulation are the 4 things that happen from the initial step of the pain, or formation of the pain signals, until the brain analyzes it and responds to that stimuli or that painful stimulation. So what is transduction? It's the first step of the pain pathway. Anybody knows?
Release of chemicals at the site of injury.
Right. So injury transcribed to action potential in pain fiber. That is a transduction. So you cut your finger, so the chemical release, which the most prominent one is prostaglandin. So that prostaglandin release, as you can see here, right, kinin, and that is going to stimulate the pain fiber. By stimulation of the pain fiber means pain fiber kind of transcribe that injury to action potential, they firing, right? And that kind of the signal is going to transfer to the brain. So the transduction happens, so that injury transcribe to the action potential in the neurons, the pain fibers. Yes.
So is that saying that non-steroidal anti-inflammatory drugs are targeting prostaglandins to reduce pain?
Yes, that's how it works.
Okay. It doesn't target bradykinin?
No, so NSAID, NSAID target the prostaglandins. So the transmission now, the action potential formed has to go to brain, right? So from the site of the injury, I cut my finger, all the way goes through the spinal cord, and from the spinal cord goes to my brain, right? So two fibers or two pain fibers are involved. A delta, which 10% of the pain fibers, and C, which is 90%. So the majority of the pain fibers are the C fibers. So where you see these fibers? So the C fibers is the majority of the pain fibers, right? Like where you can find the C fibers? Anywhere that is cause pain, right? In kidney, in lungs, GI system, heart, right? Bones, muscles, the C fibers present. So any injury to those organs is going to activate the C fibers, and that going to transmit to brain. A delta is a small amount of the pain fibers and very specific. So where you're going to find the A delta? The skin, right? The skin has all this A delta. Why? Because that's the point of contact, right, with the environment. So anything happens through the skin, so you have to have the signal that goes quick than the injury inside the body. So that's why the A delta is present in all over the skin, and A is myelinated. That means there's a protein sheet around the nerve, so that makes it the action potential move quicker. And also there is another specific of it is highly localized. If you cut the skin anywhere, so you're gonna exactly know where you have a cut, right? But if you have a kidney stone, how do you feel about it? So it's gonna be a bigger area on the side, right? When you have a heart attack, so it's gonna be chest pain all over the chest. So that's make C fibers poorly localized. So that means any organ that has a C fiber, so the pain is gonna be kind of the vague type of the pain, whereas the A delta, which is the skin, is highly localized. Like anytime you have a paper cut, you know exactly where it is, right? The location, because it has A delta. So transmission happens now. The signal that is produced by the transduction is going to go over to brain. So there are neurotransmitters. So again, we talk about chemical that involve in transduction, and that was prostaglandin. Now there are some neurotransmitters also involved in transmission. They call them excitatory neurotransmitter. That means they are going to excite the neurons. An inhibitory neurotransmitter that is kind of blocking or suppressing the neuron's action. So from the term excitatory means more action potential, more signals, more pain. So when the cells release, the neuron release substance P, that we're going to have more signal going to the brain, more pain we're going to feel. On the other hand, for the inhibitories, so endorphin that body produce or opiate that we use, they are inhibiting the process of this action potential, inhibiting the transmissions of the signal to the brain. And again, so every part of the body has this kind of dermatome map that it shows, so the brain knows, okay, if there is something happen here, so this kind of the area is going to go to the specific part of the brain, and that's how the brain realizes like where this pain coming from, where this tissue injury is happening. So the next phase is the perception. So perceptions is now the signals is all this action potential going to brain. So how brain knows what's the meaning of it, and kind of brain analyze those signals and make sense of it, which again understand as a pain. So there are some factors that is affecting the perception, and so we perceive the pain different, right? So maybe culture is different. Some culture feel like different about pain stimulations, awareness, like if you're drunk and you have injury, so you're not going to realize the pain until a couple of hours later when the alcohol is out. So emotion and moods like depression, anxiety can affect how you perceive the pain. Prior experience is important too, right? If you broke your leg before and then now you do it again, if that was a very bad experience, now as soon as accident happen, you're just going to be in extreme pain because of experience that you have from the prior injury you had. So as part of the perceptions, so we're looking at the threshold and the tolerance. So what's the difference between these two?
Pain threshold is when you can actually feel the sensation of pain, and tolerance is your max pain before you're like, I'm out of here.
This doesn't work, right?
Is he supposed to be on the speakers or something?
Yeah, he's supposed to be. I guess there's.
Honestly, you're pretty loud.
Yeah. Oh, okay. No, I was on the wrong side of it. That's why it's not working. Yeah. Because I want to save my voice. I have to scream by the end of the class. So see if that makes a difference. Right. Again, the threshold is the minimum that can cause pain for each individual. So that means, so some people you punch the wall and you don't feel the pain. I have a paper cut and they start screaming. Right? We have a different threshold. So I need stronger stimulations to cause pain. So for me to perceive that pain. Tolerance is how much I can tolerate. And this is very common with chronic pain, which means, again, so I have a pain for the long period of the time now. If you ask a person with a chronic pain, so they say, okay, as long as the pain is 2, 3, I don't mind, it's okay. But if it goes above 5 out of 10, it bothers me. So again, how much I tolerate as far as the pain goes. Some people say, okay, I can't tolerate any pain, it has to be 0. Anything above 0 is going to bother me. So that is considered as pain tolerance. And then these lovely receptors, right? So the 4 different receptors for pain that we have in brain. So the mu is the most important one. So mu, kappa are together involved more in pain and stimulation and pain management compared to the other delta and sigma. So again, these are the receptors that if we activate these receptors, we kind of decreasing amount of the pain. So when we use the opiate medications, they usually bind to these receptors and decrease amount of the pain. As you can see, all this medication that we're going to cover and talk today is involved in the mu and kappa. And then also because these receptors are non-selective, they spread some other organs, they're going to be affected with the opiate medication as a side effect of it. So urinary retention, cause sedation, decreased respiration rate, constipation, all those things, because we have these receptors all spread around the body. So that's kind of the problem that we have when we use the opiate medications. They have lots of side effects.
So the manifestations, is that saying those are the side effects of the drugs that are listed above it?
Yeah, so it's referred to the side effects of the drugs. Yes. So now if you, yes.
On the top, it says life. Why do you put yes on the pain receptor on cover yes?
Yeah, these two are not involved in pain management, right? That's why. These are not significant receptors. So if you activate these two, they don't affect the pain. But they can do other things, like the side effects. Only mu and kappa are involved in analgesia or the pain management. So that means, obviously, when you give the opiate, all these 4 is going to be activated. So activation of these 2 is going to reduce the pain. Activation of these 2 is going to cause you more side effects. Sure. So now, as part of the transmissions, right, the signal is coming. So imagine this is like a side of the injury right here, something broke. So now the transduction initiated, the signal is trying to get to the brain, right? And you know the concept of the presynaptic, postsynaptic, synaptic gap, we already talked about that. So and again, you remember like a presynaptic, they have serotonin, right? Norepinephrine, dopamine, right? So the pain fibers in the presynaptic, we have substance P. Remember, substance P is excitatory neurotransmitter, right? They're located in the presynaptic neurons. So when the action potential, when the pain fiber gets activated, the action potential goes through, it's going to release this substance P, bind to the postsynaptic, and send the signal further to the brain, right? More of this. So more severe injury happening here, more firing is going to happen, more pain fiber are going to be activated, involved in that process. More substance P going to release, more action is going to go up to the brain, which is kind of transcribed to the pain. So again, opioid receptors, right? The mu kappa are located on the presynaptic neurons, as you can see here. So in absence of the opioid medications, obviously we're going to feel the pain. But as soon as we give them opioid meds, the opioid medication goes bind to those mu and kappa receptors. The outcome is decreased amount of substance P release. And that's how they control the pain. No substance P, no pain. Make sense? So this is how opioid works. Bind to the presynaptic neurons, inhibit release of the substance P, and that decrease the action potential that they transfer to the brain. We also have endogenous ones. So this is the exogenous, means medications, but body also release some endogenous opioid, but they work the same, but they are not as strong as the exogenous one to control the pain. But that's the concept of opioid mechanism of action to control the pain. Now, so we have a different type of the nociceptive pain, visceral pain, somatic, divided to deep and superficial. So when, what's the example of the visceral pain? Kidney, liver, heart, right? So those are the example of visceral pain. So usually they're inside the abdomen, right? So the pain is poorly localized. That means it's going through which fiber? C. Deep somatic pain. Where you find that pain? Joints, ligaments, bones, muscles. Poorly localized, C fiber. And then we have superficial somatic pain, where this one is? Skin. Well localized or highly localized, which means going through which fiber? A delta. Very good. Right? So again, you can kind of differentiate this different pain. What's the origin of the pain fiber they're coming from? And the opioid is the main treatment for these nociceptive pain. So the neuropathic pain. Again, there is something wrong with the nerve. It's either injured, like you cut the nerve, right? Or damage the nerve, or there is some imbalance in electrolytes and action potential going on in the nerve that cause this pain. The presentation. So what's the nociceptive presentation, nociceptive pain? How you describe it? Achy, pressure, throbbing, right? How about the neuropathic pain? How you describe it? Pins and needles, numbing, burning, right? Tingling. So again, the presentation is kind of different, and as we said earlier, anticonvulsant is more effective for neuropathic pain than the nociceptive. So again, the treatment is kind of the separate as well. So we have acute and chronic pain. So it's just a matter of the time. So if you have a pain less than 3 to 6 months, again here is said less than 3 months. Some textbook is coming with 6 months. So anywhere below this 3 to 6 months, pain is considered as acute pain. And then when we have acute pain, it's like a stress, right? So what you're gonna see, if you have a pain for like 2-3 days, what change is gonna happen? It's like a SNS and cortisol release, right? Again, cardiovascular is gonna be affected, heart rate goes up, blood pressure goes up, glucose goes up, right? So those are the presentation of acute pain or the physiologic changes. So the pain is a pain anyhow. So the person comes and say, oh, I have an 8 out of 10 headache, right? But that pain, if it is severe enough, so they can affect the blood pressure and the heart rate. So the heart rate is going to be higher. If you check the blood sugar, probably it's going to be higher than usual. In case of the chronic pain, it's more than 6 months, right? Or more than 3 to 6 months. So if the pain lasts more than that duration of the time after the 6 months, they consider the pain as a chronic pain. And usually the chronic pain is a confusing part of the pain management because again, it's a presentation. So let's say you have an injury, nociceptive pain starts. Now the injury is healed, but the pain is still there, right? And then it's subjective, right? You can't find, it's not a lab, you can order and say, okay, your CBC is elevated, right? That's why you have pain. You can't find anything. But again, still patients suffer from the pain, right? And the duration more than 6 months, now you can see there's chronic pain. So again, the treatment is going to be difficult because now, since they're not apparent injury to the cells and the tissue, so usually like opioid medication doesn't help much. I mean, it helps, but again, so how long you can stay on those opioid medications? So that's why now they try to, because again, chronic pain is associated with lots of opioid use in the past. Now what they do is the pain management, right? They try to reduce the amount of opioid use and do some other, like a physical therapy, non-pharmacological interventions to control this chronic pain. But also, as far as the nurses and healthcare staff goes, chronic pain is going to be problematic for us too, because many times they feel like the patient is seeking or the medication or drug seeker, like because they can't find anything, just say, okay, they just excuse it to get narco. So it's something to think about. Again, the chronic pain is real, so it can happen. You don't have any evidence behind that chronic pain. So, of course, you're going to use your judgment to evaluate them for the chronic pain. But again, pain is what patients tell you, right? That's, again, go back to that ideas.
What is the E and P stand for?
Etiology and pathogenesis. And CM is the clinical manifestation. So again, in the chronic manifestations of the chronic pain, so apart from the pain, now those physiologic change is not common as we saw in acute pain. So mainly here is psychological changes. Patient is not able to sleep, they have, poor concentration, they feel depressed, sad, obviously frustrated, because again, they don't want to be in pain. Especially if nobody believes them too, right? They make it even harder. Because now everybody say, okay, like, I don't trust you or I don't believe you. So it's going to affect them mentally. So refer pain, and I want you to know two things out of the refer pain. So two types of refer pain is one, heart attack pain, right? And the other one is liver and gallbladder pains. So again, what is the refer pain for the heart attack? So it's like a left side chest, but it goes to left arm and left side of the neck and head, right? So sometimes the patient come with unusual, so they just have the left arm pain. So So you have to rule out if they are meeting the criteria for heart attack, MI, you have to rule it out. So just don't say if they don't have a chest pain, maybe it's the muscle, but you have to rule it out. And the other one is the gallbladder and the liver. Where is the liver? On the right upper side of the abdomen, right? So what is the common presentation as a referred pain goes? Patient comes with right shoulder pain, right? So rather than having a pain in the upper right quadrant, so they come with the right shoulder. Again, if they meet the criteria for the liver and gallbladder pain, you need to assess them for that. Just don't say it's a shoulder issue. And the treatment again, so we're going to focus on the opiate today and talk about opiate medications. But again, as you can see, you can, heat compression, cold compression, local anesthetics, like a lidocaine patch or lidocaine ointment, right? So sometimes those can help, and as well as non-medications like hypnosis, distraction, relaxation, all those things that not medication. Again, especially for chronic pain, because you don't want them to be dependent on opiate. So anything else that can help to reduce amount of opiate that they take, so it's going to be beneficial to the patient. Question? Now let's move to medications. Blood-brain barrier, right? Remember what was blood-brain barrier? What was it? Tight junction in brain vessels, right? They don't have that gap. Why? Protect the brain, right? They don't want everything go through. What is the characteristic of blood-brain barrier? What type of substance goes through? Lipid soluble, right? In order to cross the blood-brain barriers, so lipid soluble. Then that means the medications need to be lipid soluble to have crossing of the brain. And the opiate are the one that they have a very good lipid solubility, right? That's why they cross the brain.
You said opiates have really good lipid solubility?
Yes. Opiate. So this is slide just talking about some side effect of the opiate goes away over time, some doesn't. Like nausea, vomiting, if it's related to opiate, it's going to be subside in a couple of weeks or a couple of days after they start. Constipation never goes away, right? Again, the body, as far as the side effect goes, again, so some of the side effect of the opiate is going to be decreased over time, some they don't. Next is the tolerance, physical dependence, and addiction, which is not on the slide. So, do you know what is tolerance? Receptor doesn't respond to medication, right? So they lose their sensitivity. Two things happen: the number of the receptor drops, and then receptors are less sensitive to that drug. And the solution is to get the same response to increase the dose. That's what happened with the opiate, right? If you take morphine for 2 weeks, 2 milligrams doesn't work anymore, so you have to bump it up to 4. You take another month, you have to go to 6 and 8 and 10, right? So it's going to go up because there is a tolerance. So higher you go on the medication dose, it's going to be what? What concern you have? Toxicity, right? Higher dose, more side effects, and also toxicity, because higher the dose goes, you'll move toward the toxicity level, right? You remember therapeutic range? Physical dependence. What's a physical dependence? And how that's different from addiction. So the body rely on the substance. They become dependent, right? Every time you use opiate more than a week or 2 weeks, you're gonna have that opiate has to come in. That doesn't mean I am addicted to opiate. I'm just dependent. As long as I have an injury, I have pain, maybe like I broke my leg, so I need opiate for 3 months, right? I take it for 3 months, and then they taper me off, and I'm off the opiate, and I never use it. But with physical dependence, if you abruptly stop it, like if you stop right away and don't decrease the amount, what's going to happen? Withdraw, right? So, which is very uncomfortable. But again, so the patient get confused, physical dependent, they don't want to take it. They say, okay, I'm going to be addicted. This is not addiction, because as soon as your pain is gone, they're going to taper you off, and you're not going to come back to the opiate again, ever, unless you have another pain. Yes.
Are there ever times when physical dependence is not seen with tolerance, like, or there's, like, yeah?
Yeah, these are the two different subjects. So the tolerance means that you have to increase the dose because they become less sensitive to it. Physical dependence, that means the cells are dependent on that substance after a week or two.
But does tolerance influence physical dependence?
No.
Or what makes somebody physically dependent?
If you take any control meds, after 2 weeks you are dependent. I mean, dependent means if I don't take it, I'm going to go through withdrawal.
600 is strong.
Like, for everything, opiate, benzodiazepines, barbiturates, so any kind of the control meds. If you take it after a certain time, now your body is going to respond if you take them away right away.
Is it 2 weeks or it varies?
Yeah, usually it's 1 to 2 weeks. But again, so what is addiction then? So addiction is many things involved in addiction. First of all, you take it for just euphoria, for your different purpose than the pain management, right? So if you take that opiate for something rather than pain management, because you want to be high, so that's addiction. Addiction is that you cannot stop after they tell you that you have to stop, right? You're still taking it. If you can't find a prescription, you go to the street and buy it. Addiction means you don't care anymore. The personality changed. So you lose a job, you don't care. You lose the family, you don't care, right? So that's a profound effect on your everyday life. So that's become addiction. So you have to kind of differentiate these two. Again, what's the percentage if you start someone on opiate, are they going to be addicted? Like let's say you want to take opiate for 3 months. What's the chance to become addicted?
Depends on the opiate.
Just throw the number.
20%.
90%.
1%.
Oh.
There's only 1% chance you become addicted to the opiate. So that means yes, out of 100, 1% become addicted, even though they take it for pain. But stop taking because you're one of those 100. You know what I mean? But again, so the number is very low, right? So you don't want the patient suffer pain because they're scared of addiction. Especially, I mean, if there is a family history of addiction, so you're probably going to have higher risk. But like the general population is only 1%.
That's only 1% if you started taking it for its intended purpose, correct? Not if you just started taking it for whatever reason.
Yes, 1% of the people that they take opiate for management of pain
Who originally started.
become addicted to it. But 99%, they become physically dependent and they come off and they function without the opiate.
Are the risk factors like genetic?
Yes, if you have family history of the addiction, the chance is going to be higher if you go on opiate and become addicted. Because the addiction is genetic. It runs in the family, so you can tell. If you have alcoholic in the family, if you take opiate, you have that doesn't mean that you're 100% going to be addicted to, but your chance is more than 1%.
So with the abrupt discontinuation for would that increase this 1% addiction? Would there be an increased risk factor of addiction if there is abrupt discontinuation? Would that increase the risk factor for addiction?
No, just abrupt withdrawal symptoms. It's gonna make you comfortable. Again, you can just stop the opiate. Again, so you're gonna have really hard time for a week. It's not gonna kill you. It's doable, but you're gonna be very miserable for a week, and it goes away. But again, what they do is they taper off. Like if you take 6 milligrams of morphine, they drop it to 4 over a couple of days, and then drop it to 2 couple of days, and then you're off. That is prevent this withdrawal syndrome. But it doesn't make anything to the addiction. But But I mean, if you're addicted, like if you're alcoholic, you have to watch for the opiate, right? If you're alcoholic, sober, you get the narcotic, obviously you're going to relapse. Make sense? If you have a history of addiction, that's a different story now. You have to stay away from it. And again, so we have endogenous, that means the body produces enkephalin and endorphin. So, which again, you don't have control over this endogenous, right? They're just going to release through the neurons, and that is going to partially help with controlling the pain, but it's not enough. So we need these opiate medications. So we have three groups of the opiates: agonist, antagonist, and antagonist, right? Agonist, antagonist, also known as a partial agonist. So the opiate agonist, which is the very common aspect of this opiate that patient use, right? And they divide to two groups, strong and moderate. Like for example, morphine is the strong, so we're gonna go individually in those groups. But again, there are some side effects of the opiate, right? So do you know any side effects?
Respiration.
Right, the respiration rate drops. Constipation, nausea, vomiting, dry mouth. Yeah, I'm not aware of that.
Itchy.
Yeah, they feel itchy, but that's yes. Itchy. What else?
Do they make you retain water?
What, that means edema?
Mm-hmm.
So urinary retention, yes.
Yeah.
They cause urinary retention. And then also, I mean, again, analgesia is the effect of this medication. This is pain, reducing pain is what we looking for. But again, euphoria is a problem with addictions, right? This euphoria is the part of this substance that make you to stick to it. Sedation, make you sleepy, right? Slow down the awareness, suppress that alert and aware. And some others that are listed here as well. So constriction of the pupil is very common with the opiate as well. So some others here. Again, so the things that one thing about the opiate side effect, doesn't matter what kind, which one, they all have the same side effects. Again, a strong opiate, they have stronger side effect, like constipation is stronger than the moderate. Like if you take the lauded, your constipation rate is much higher than if you take narco, which is the moderate opiate, right? But they have constipation, they have decrease in respiration rate. So, partial. So I want you to know buprenorphine, also known as Suboxone, is the common agonist antagonist that we're going to talk about that. So what's the agonist antagonist? Why we combine this? Because we're going to control the agonist effect, right? We want to make sure they're not abusing it. Because anything with the agonist alone has a tendency of abuse. But if you put the antagonist, it's kind of controlling that euphoria feeling that they might get. So
Is it kind of like the agonist like will excite everything and then the antagonist is trying to block
yeah, they're at the same time, that means it's not going to be purely agonist, so it's not going to go all the way to the top. Antagonist also they're present to control some of those receptors. I mean, in practice, still is not exactly what they wanted, or in theory, so some people are abusing it still. And antagonists, you already know, right? Naloxone or Narcan, we already talked in prior lecture that this is only work when you have agonists in the system. Like if I give you Narcan right now, nothing gonna happen, right? Because Narcan has affinity, but it doesn't have what? intrinsic activity. So it binds to the receptor, doesn't do any change to the cell, but it doesn't allow the agonist to bind to, right? And this is only used for opioid overdose. Anytime the person has overdose, we go to the Narcan to reverse the effect of the agonist. So again, looking at the strong opiate, morphine and others that we're going to talk about those. So we already talked about side effects, toxicity. If you overdose on the opiate, what's going to happen? What's the presentation? The triad is coma, respiratory depression, pinpoint pupils, right? So the patient is unconscious. The people are very constricted, right? Not responding to the light. And rate of the breathing drop below 12, right? Any number below that. What do you do? Narcan them. So again, in San Francisco, Oakland, the overdose was, I don't know if it's still high, but for the period of the time, they were distributing Narcan to everyone. But you could have had Narcan with you. So if you see a person on the street has these three things, that means they overdosed. So you have to Narcan them. But one thing about Narcan, as soon as Narcan goes to the system, what's going to happen now? They wake up, right? Because the Narcan take those agonists off. So they're not going to be happy at that moment because all that drug that they use is gone. They're going to have a really hard time after. But anyhow, that's something that you need to do to make sure you save the patient's life. But again, make sure they are unconscious. Like make sure you have a good shake because you know how they do when they use the drug, they just sedate them, right? They are very in that over the moon phase. If you Narcan, that person is going to punch you. Just make sure they are unconscious. You don't, because all the money and the effort that they had is going to go away. Again, morphine has all different routes of administration. So oral, IM, IV, sub-Q, epidural, and very common in the hospital setting to use this. It's not very lipid soluble, still is very lipid soluble. So this is comparing to the other steroid, like compared to the Dilaudid and fentanyl. But still morphine has good amount of lipid solubility, right? And other thing is all the opioid has a short half-life except the methadone that we're going to cover here. So the methadone, yes. So they all have somewhere around 4 hours half-life. So that means you have to repeat the dose several times through the day. If the patient takes morphine every so the number 4 should be like a universal, anywhere around the number 4 hours, right? Dilaudid every 4 hours. Fentanyl every 4 hours. Narco, Percocet, all of these opiates except the methadone. It's going to be several times a day because they have a short half-life. Again, if you stop abruptly when they are physically dependent, so they're going to go through the withdrawal syndromes or symptoms. So what are those symptoms? What's the withdrawal from opiate? Anything that opiate did is going to go up back, right? You reverse it. Opiate decrease the pain. You're going to feel the pain, right? Opiate cause constipation. You're going to have diarrhea. Opiate slow down the brain functions, right? They feel feeling well, right? Feeling very good. Now they're going to feel anxious, restless, agitated, right? So opiate make the people constricted. Now it's open. Make sense? Urinary retention. Now they have to go bathroom. So again, you can just reverse everything that opiate does to get to the withdrawal syndrome. Opposite. And that happens if you Narcan the patients when they just use heroin. These are all going to happen to them. Sneezing, yawning, sweaty.
Why does it make you sneeze?
Because opiate is affecting the histamine release.
Oh, okay.
So the itchiness and the sneeze, like you, is mimic that allergy because it's working through the histamine. Okay? So the drug-drug interaction, again, is not just morphine. All these opiates can have interaction with some of this medication. CNS depressant, what's the interaction? Respiratory depression, right? So CNS depressants are to slow down the respiration as well as opiate. Anticholinergic drugs, urinary retention. Hypertensive drugs, opiate cause hypertension or orthostatic hypertension. So again, just a general overview. It's not going to be an exam questions, but to know that those symptoms that is causing by opiate, so if you take medication that cause the same thing, kind of to synergize those effects. The other strong opiate is fentanyl. Everybody knows fentanyl, heard the stories. Fentanyl overdose, right? Street drugs, they're mixing all these things, and the person who does it doesn't do a good job, the ratio-wise. All of a sudden put more fentanyl in that patch, and whoever used that patch is going to be overdosing because fentanyl is very strong, right? 100 times more potent than morphine. That's why the fentanyl is a microgram. Morphine and Dilaudid unit is milligram, right? Fentanyl is the microgram because it's very potent. Microgram is 1/1000th of the milligram, right? So for that purpose, fentanyl again is just a specific condition that we use. One thing is anesthesia. If you have a surgery and stuff, like a procedure, they add fentanyl to that medications. And also commonly use the fentanyl patch for chronic pain. Patch is releasing fentanyl very slowly over like 2-3 weeks. So that helps with the chronic pain patients. But what they do, sometimes people chew the patch, cook the patch, because it's released more fentanyl. Right? If you chew the patch, it's released more. If you cook it, release all those fentanyl and then they inject it. So do stuff to it, but again, so it's very dangerous medications. That's why they die because of overdose. The other thing with this strong is not just the potency, but the lipid soluble. The fentanyl and heroin has the highest lipid solubility. So that's why they have very high effect. But that means majority of these heroin, when they use, and the fentanyl goes through the brain right away, right? In like short period of the time, all this heroin and the fentanyl is going to be in brain. So that's why they feel, in heaven. So, and that's why the person mainly, like one of the factors is when you talk to people that they use substance, like the first time they use heroin, they never forget. And every time they use to get to that first place that they've been. And they never get to it, right? Because of the tolerance. So again, but lipid solubility is very high with fentanyl and heroin and those synthetic drugs. So that means they're going to cross the brain very quick. And that's why they feel that euphoria. That feel like very happy. There is no problem, there is no pain, no anxiety. You always want to be there, but again, obviously, you become addicted. So out of this list, again, as you can see, we have more, but I just want to cover the methadone. So you heard methadone clinic, right? For people that use street drugs. So there are methadone clinic that you can go and take methadone for free, right? They try to replace the street drugs with the methadone. Methadone is the one that doesn't have the peak. So you cannot abuse the methadone for euphoria. So, but it has a very long half-life, so that's why stay in the system, like once or twice a day you won't need to take it easy.
Is methadone the same as Suboxone?
Methadone is the same as morphine and the Dilaudid.
What's the other name for Suboxone?
Buprenorphine. So the methadone is another type of the strong opiate, right? But again, very commonly used for those detox purpose. So that person, try to change their life. Like how if you use the street drugs, they have a different kind of the lifestyle, right? It's affecting your function and everyday life. So usually methadone has become alternative to use for those street drugs. But again, methadone is the oral medications, is used in those kind of the methadone clinics, so to, kind of treat, or not just treat, but again, it's just to replace the addiction that they have. So you just you give them more control, kind of the drugs that they can have access to it.
So would
Right.
a patient on methadone still go through withdrawal then?
No. Yeah, because this is the strong, right? Imagine you're replacing one strong with another strong. The only difference is the half-life, so you don't have to get it. You don't have to take methadone like 5 times a day, like if you take morphine.
You don't get addicted because you have the peak, but the other one, I think.
Yeah, you don't get addicted because it doesn't have a peak. I mean, by addiction means still, because you have addictions, now you become on the methadone, and sometimes you stop the methadone with street drugs, they go back and forth. But methadone, no, I mean, like, it doesn't give you that high feeling. Okay, it doesn't have a peak. Again, the peak is that these medications, how quick they can get to the brain. Methadone is very slow release, so it doesn't get quickly to brain, so that's why you don't have the euphoria. But again, obviously it's a strong opioid, right? So you can replace those. So another one which is common with the morphine in the hospital setting is the hydromorphone or Dilaudid. So this is also very commonly used in medical flu. It's more potent than the morphine, like 7 to 1. And also it has higher peak than the morphine. So it's more lipid soluble than morphine. So that's make it highly addictive. And the slide means, again, tendency of become addicted to Dilaudid and fentanyl is higher than the morphine. But again, this is in a different type of the strong opioid that they can use in the hospital setting. Now, so when person is in the hospital, when they go through the acute phase of the procedure, like it makes sense to have those strong, but when they release them, usually they switch to the moderate one, because now they want to have the moderate type of opioid that they can take for the longer period of the time. So these are like oral medications, and we're going to go over a few of those. But again, so the side effects are the same. Toxicity can happen if you overdose in this. It can be fatal if you overdose, everything. But for example, the constipation is stronger with the morphine and Dilaudid than narco. So the strong opioid has a stronger constipation. They have a more decrease in respiration rate than moderate opioid. So one of these moderate is called OxyContin or oxycodone, which again, this is short half-life, but this one again, so it's a slightly longer half-life than the others. But anyhow, so this similar to the other opioid, they have the same kind of side effect, toxicity, concern about abuse. Everything is going to be the same, and it's the oral medication, so they're more manageable at home to take it. Vicodin is another options, or hydrocodone. So we have oxycodone, right? Oxycodone and hydrocodone are the two moderate. So the hydrocodone is weaker than oxycodone. Between the moderate, there still is difference. So Vicodin or Percocet, so these are, Vicodin and Narco, not the Percocet. So hydrocodone is the Vicodin and the Narco, so are the hydrocodone that again is combined with the aspirin, Tylenol, and so usually it's like 5-10 milligrams several times a day if they prescribe them. So, but again, tolerance, remember, is happening, physical dependence happening, doesn't matter which one we use, the strong or moderate. So now the partial agonist or agonist antagonist, forget about the top part. So buprenorphine or Suboxone is the one that can be patched in 7 days, or the sublingual. Again, it has a really high first pass effect. Right? Anytime you see sublingual, what does it mean? It has a high first pass effect. right? That means it's not going to leave us with much medication. So that's why they do the sublingual. If swallowed is Suboxone, it doesn't have much of effect. But again, these are the two ways of using it. So these agonist antagonists, again, the half-life is longer than the opiate, like a pure opiate as well. So usually they take it once or twice a day if they take it sublingual, or once a week if they do the patch. So main purpose for this is the detox. If the patient comes off the street drugs, they can replace it with this, or if the patient has chronic pain. It's very common, Suboxone for the chronic pain to use.
How quickly into their detox can you use this
In detox,
Yeah.
so
Like immediately, or you need to wait like a couple of hours or days?
So I mean, by wait means if the person is take narco is like a couple of hours, right? If I just took narco right now and coming to the detox, maybe they give like an hour or two. But if I take a couple of hours, they start right away. Again, remember all those are short act, right? 4 to 6 hours. You can start any time in that duration.
Can you just say what you said earlier? You said the half-life is longer or shorter than
So this one has a longer half-life. Again, Suboxone is like once or twice a day. Or the patch, which is 7 days. Again, usually patch is for the longer period of time because they have released the medication slowly through the skin. All the patch are like a couple of days, 1 week, 1 month. So again, when you do the pain medications, right, what you need to do? Pain assessment, right? Why are you giving a pain medication? Because they have pain. You always have to document what's the pain, and you did, what's that mnemonic in health assessment you do? Loud cards, right? So you have to do loud cards, right? And then when you give the narcotic or the opiate, so you have to assess the pain 1 hour after opiate administration. What else are you going to do? When you do the opiate, that you know a little more about the opiate.
Probably monitor respirations.
Check the vital signs, document the respiration rate, and O2 sat. Before the administration and 1 hour after administration, right? Because again, you know that opiate cause hypertension, opiate decrease respiration rate, so you want to assess those and document. And the other one is about the dosing. So opiate can be scheduled or as needed. So with the way that it works, they just do the baseline, the schedule, like every 4 hours they get 2 milligrams of morphine, and they do as needed on top of that. So if that 2 milligrams doesn't help, you always can ask for more, right? That order is kind of standard order. So you have the schedule and the PRN, or as needed, to make sure the patient doesn't suffer from pain. Because again, if you don't have as needed, what's going to happen? You have to call the provider, get the order, approved by pharmacy. It's going to take like 45 minutes. To prevent that, so they kind of schedule. But again, it's a schedule one you have to, because sometimes if the patient doesn't have much of pain, still you're going to go with the schedule. So don't stop the schedule, right? Because that's going to cause pain. So usually you're going to give them a schedule if it's ordered, even though when the patient doesn't have a pain. Because if you don't do, the pain is coming back. Always you're looking for the overdose. Like when you give them so what's happening if respiration rate is 10? The patient is ordered a narcotic. So you want to go give them morphine, right? And then you check the respiration rate is 10. What do you do? No, you don't. Again, the criteria, right? This whole thing, you know that this respiration is going to drop. It's already below that level, so you're not going to give. That's why you do the respiration rate and O2 sat, because if it's not normal, you're not going to give it. Make sense? That's the whole purpose, because otherwise, that if you give that, it's going to drop them even further. Yes.
Would it be appropriate to ask the doctor to switch medication for this?
Yeah, find something else to alternate the pain. You need to find something that not opiate if the respiration rate drops. So the other thing is this PCA. This is the pump they use. They call patient control analgesia, right? So again, the pump is kind of the programmed. They have a certain program as far as how much medication they can release. But this is in control of the patient. So the patient can, press the button and that release the opioid medication. But again, since it's programmed, you have to educate the patient that you can't just push it more, get more opioid medication. It doesn't work that way. It only releases certain amount. After that, you have to wait. Make sense? So that again, it's the good things about this. Sometimes, it's easier for patients because they can control that release of the medication rather than waiting for the nurse to come. And sometimes that is going to take some time for the nurse to get to that patient. And then antagonist, naloxone, right? So Narcan, you already know how it works. It's very short half-life. So it's like 20 minutes, 30 minutes, the half-life. So that means if the one dose of Narcan doesn't respond, you have to repeat the dose. Like if one dose doesn't do it, you can repeat several times, but you have to repeat it every 30 minutes. And again, so they have a different type of or different route of the administrations. So it has a nasal, it has IV, what else do they have? And sub-Q, right? So in hospital settings, sometimes they can do the IV drips of the Narcan if the patient has a high dose of opiate. But obviously at the street, you cannot do that. On the street, you have a spray or you have the sub-Q injection. So now the last thing before we take a break is the non-opioid medications, right? That they work central and with the brain cells. And but again, they don't consider them as opiates. So two medications that we have, Ultram or Tramadol and Clonidine, right? So the Ultram or Tramadol, so it doesn't consider as opiate, but it still is affecting mu receptors, right? And then also is affecting some of those excitatory neurotransmitters, the way that it works. So it can work for the moderate to severe, like if the opiate cause respiratory depression, so Ultram will become a choice. It has a PO, it has an IM injection that you can do. One thing about the Ultram, so obviously abuse still is going to be an issue, but the suicide. So if the person is increasing the chance of the suicide or risk of the suicide ideation, so that means the person is depressed or having a suicide ideation, that is not a good choice to use. And Clonidine is the alpha-2 agonist. What was the alpha-2 agonist? This is the alpha-2 agonist. What's the alpha-2 agonist? What it does? It goes to the brain, inhibit the norepinephrine release, decrease the blood pressure, right? Does the same thing for the pain too. Norepinephrine is involved in the pain. So, what kind of medication is this? Antihypertensive medication. So that means Clonidine we can use for pain, but not acute, chronic pain. So Clonidine used for detox and chronic pain, which is related to it has many other indications, right? But it's antihypertensive medication to start with. It's an alpha-2 agonist, right? So what you're going to do when you use this for detox or chronic pain? Blood pressure. Check the blood pressure before you're giving this, because it's going to cause decrease in blood pressure, right? If the blood pressure is low, you can't give it. Question? 10 minutes?